Chapter 4, Causes and Evaluation of Hypoxemia. Okay, before we begin with evaluating the hypoxemias, we do have a high-yield topic to discuss, and that is the idea of regional differences in interpleural pressure, which is going to lead us to an incredibly high-yield concept, which is VQ matching. All right, let's start with regional differences in interpleural pressure. Notice our chest, this is in an upright individual. If we look at the apex, we're at FRC. The apex, interpleural pressure is -10, but as we move down, remember that pressure equal height times gravity times density. So as I move down the chest wall, interpleural pressure is increasing, i.e. it is becoming less negative. And the highest interpleural pressure is going to be at the base of the lung. So notice it goes down to about -2.5. All right. Let's put in our transmural pressure gradients. We're at FRC, so we know alveolar pressure is 0. So at the apex, interpleural pressure is -10, alveolar 0, so that's a +10. About midway in the lung, where we have -5 interpleural, that's going to be a +5 transmural. And then at the bottom, where we have the -2.5, that means I have a transmural of 2.5. All right, why do I bring this in? Because at the top of the lung, at the apex of the lung, we have a greater transmural, which means those alveoli are more distended. At the bottom of the lung, we have less transmural, therefore those alveoli are less distended. And hopefully when I said less distended and more distended, you immediately thought about the compliance aspect. The less distended alveoli at the base are going to be more compliant. At low lung volumes, compliance is high. At high lung volumes, compliance is low. Just applying what we already know. So the base of the lung is going to have more compliant alveoli. Therefore, when I take a breath, I'm going to get more ventilation at the base compared to the apex. And that's because of this gradient of interpleural pressure. To put that idea on a graph, here's our pressure volume graph, our compliance. Remember, the slope of the line is compliance. At the base, we have less transmural pressure gradient, so we're on a steeper part of the curve than we are at the apex. We could plot this as transmural, we could plot it as interpleural pressure, and that's what we see on this graph is we're plotting it actually as interpleural pressure. So again, we could just change that to transmural or transpulmonary. But bottom line, base of the lung, we're on a steeper part of the compliance curve. It's less distended, it's more compliant. Therefore, I get more ventilation compared to the apex. Blood flow is also going to be influenced by gravity. At the base, pressure is higher, so intravascular pressure in the pulmonary arteries is higher compared to arteries at the apex, because we're going against gravity, going up. So intravascular pressure is less in the apex. So as a result, we're going to have more blood flow to the base of the lung compared to the apex. All right, here's a graph illustrating the same thing that we just said, but we're going to put it together. Notice here we are at the base on the left, apex to the right. This graph shows ventilation in the green line. I have more ventilation at the base than I do the apex. Blue line shows blood flow. I have more blood flow at the base than I do the apex. But what this graph shows and puts together for us is the VQ relationship. VQ. It's all about VQ. VQ is huge. It is very high yield. It is a critically important aspect of physiology and medicine. What's important is the relationship of ventilation to perfusion. Again, V dot A is alveolar ventilation, Q is blood flow, we just call it perfusion. The alveolar gases are ultimately determined by the VQ relationship. It is not the absolute amount of ventilation. It is not the absolute amount of blood flow. It is the relationship of ventilation to perfusion. That's what's ultimately going to determine the alveolar gases. And remember, both gases equilibrate, so the alveolar gases ultimately determine the arterial blood gases. That's why it's so crucial. It is the relationship of the two to one another that ultimately determines the alveolar gases. That's what VQ is. All right, let's start with the following idea. Let's say that a VQ of 1 is perfect. Now, hopefully that's not too much of a stretch. All right, a VQ of 1, this is a ratio, ventilation to perfusion, would mean ventilation and perfusion are perfectly matched. Because if they're the same, perfectly matched, then the ratio will be 1. And let's say that that's perfect VQ. And if I have perfect VQ, then I'm going to have perfect textbook alveolar gases. PCO2 will be 40, PO2 will be 100, pH will be 7.4. So a perfect VQ, perfect matching is 1. And that gives me textbook alveolar gases. Okay, we'll start with that construct. All right, now how are we going to work with VQ? I recommend using this because we already know this. We should know this very, very well in our preparation for step 1. It's a huge physiologic construct, very important from a clinical perspective. CO2 is inversely related to ventilation. That's what this is saying. CO2 is inversely related to ventilation. All right, so notice, as I move toward the base of the lung, VQ is going down. Yes, I have more ventilation than the apex, but proportionally I have even more blood flow. Notice the lines. Even though both are greater than the apex, the blood flow is higher than the ventilation, so VQ is going down. I have more blood flow than ventilation, so stated another way, I have inadequate ventilation for this amount of blood flow. It is effectively hypoventilating. I have low alveolar ventilation compared to the blood flow. Well, if it's underventilated, then CO2 is going to go up, oxygen is going to fall. They're always going to go in opposite direction. All right? So, if it's underventilated, CO2 goes up, oxygen falls. CO2 is an acid, so therefore pH falls. So as VQ goes down, it is relatively underventilated, meaning CO2 rises and oxygen falls. Now, let's think about what the extreme is mathematically to a decreasing VQ. Hopefully you said that would be a VQ of 0. 0 ventilation, but I do have blood flow. That would be the ultimate extreme of dropping VQ. It has blood flow, but no ventilation. Well, this is a shunt. That's exactly what a right to left shunt is. It's blood going through the lung that is not exchanging gas. And it's not going to exchange gas if I don't have any alveolar ventilation. So that's venous blood. High in carbon dioxide, low in oxygen. So as VQ falls, CO2 goes up, oxygen falls. To the extreme, which is a shunt. So notice at the base of the lung I have a low VQ, therefore I'm going to have high CO2, low O2 in the base of the lung. In the apex, yes, I have less ventilation than I do the base. Yes, I have less blood flow than I do the base. But what matters is VQ. Notice that as I go toward the apex, there's more ventilation than blood flow. So VQ is going up. VQ is going up as I go toward the apex. So now, instead of being underventilated, low VQ, I'm moving toward a higher VQ. It is effectively over-ventilated. And if it's over-ventilated, then CO2 is going to fall, oxygen goes up. Since CO2 is an acid, if it goes down, then pH goes up. So in the apex, my VQ has gone up. As a result, I'm going to have high oxygen, low CO2 in the apex. Now let's think mathematically, what's the extreme? The extreme would be dividing by 0. No blood flow. Ventilation, but no blood flow. Well, that's infinite. That's infinite. It also has a name that we've described earlier in the respiratory section. What do we call areas that are ventilated but not perfused? Very well done. If you said alveolar dead space, you hit it right on the money. This is alveolar dead space. Remember, there's no CO2 in alveolar dead space. So as VQ goes up, CO2 is falling, oxygen's going up. Since CO2 is falling, pH goes up because CO2 is an acid. To the extreme, which is alveolar dead space, which has no CO2. VQ, VQ, very, very important construct because VQ determines the alveolar gases. All right, this is called a VQ ratio line, and you know, everything in life is a continuum. It's a continuum. The extremes of VQ, notice the axes. X-axis is PO2, the y-axis is CO2. As VQ goes down, oxygen falls, CO2 rises. To the extreme, which is a shunt, VQ 0. Here we'll have venous gases. Notice at the shunt, we have a PO2 of about 40, PCO2 of about 47. Those are our venous gases. So as VQ falls, it starts looking more and more like a shunt. And if we can remember it that way, well, okay, it's underventilated, so CO2 is going to rise, oxygen is going to fall. Going to the right, as VQ goes up, PO2 goes up, and CO2 falls. It is overventilated, so CO2 falls, oxygen goes up. To the extreme, which is alveolar dead space. Notice we have no CO2 in alveolar dead space. We have high oxygen, but no CO2. If you can see on the graph, you see the line that says optimum. That would be perfect, VQ matching, VQ1. PO2 would be 100, PCO2 would be 40. The base is lower VQ. That's why there's less oxygen, more CO2. The apex is higher VQ. That's why we have higher oxygen and lower CO2. This brings us to the idea of a bug, tuberculosis. Where does tuberculosis tend to reside? Yeah, in the apex of the lung. Tuberculosis is a bug that likes oxygen. Where do I have more oxygen? The apex. Why do I have more oxygen? Not because there's more ventilation, right? It's because there's a higher VQ. VQ determines the alveolar gases. All right, let's work a little bit with VQ. We're going to have two units, A and B. A and B. And the VQ in A is 0.62. The VQ in B is 0.73. First thing you should do is think about what the relative amount of oxygen, CO2, and pH is in A compared to B. All right. B is better ventilated, right, compared to A. Or you could say A is underventilated compared to B. So because A has a lower VQ, hopefully you said, okay, what's going to happen with oxygen? VQ goes down, oxygen goes down. So A is going to have a lower oxygen than B. As VQ goes down, CO2 goes up. So CO2 is going to be higher in A than B. And since CO2 is higher, pH will be lower. Now that we've defined that all in our heads, we can answer the question. Which is going to have the highest CO2? Well, we just said A, because VQ is lower. It's relatively underventilated, so CO2 goes up. Which is going to have the higher oxygen? Well, B, because it has a higher VQ. As VQ goes up, oxygen goes up. All right, how about capillary pH? Well, if A has a higher CO2, then it's going to have a lower pH. But it asks which lung unit has the greatest pH. So that's B. So that's working with VQ. Another example of working with VQ, let's say we have a person who inhales a peanut. This peanut lodges in a peripheral airway. Ouch, ouch. Yeah, that would hurt. But the point is, it's going to block ventilation. And if I block ventilation and I still have blood flow, that creates a, hopefully you can say, shunt. Exactly. This is going to be VQ0, a shunt. Okay? VQ0, a shunt. As VQ goes down, CO2 goes, yes, CO2 goes up. As VQ goes down, PO2 goes down. Okay? It is under-ventilated. Since CO2 is going up, CO2 is an acid, so pH goes down. Exactly. Now, what about blood flow to that unit? Well, if alveolar PO2 is going down, if it becomes hypoxic, that evokes hypoxic vasoconstriction. That's going to vasoconstrict in that area. So, blocking the airway produces a shunt. That makes CO2 go up, oxygen go down. The low alveolar PO2 is going to cause hypoxic vasoconstriction to, if you think about it, the rationale for this, why this would be beneficial. I have an area that has poor ventilation. Well, I don't want blood flow to go there. I want to divert it to better ventilated regions of the lung. So that's why hypoxic vasoconstriction is beneficial. So areas that have low VQ ratios, even if it's not a pure shunt, it could just be low VQ. Because as VQ goes down, oxygen falls. Those are going to be associated with hypoxic vasoconstriction also. If we get enough of the lung impacted by low VQ and thus alveolar hypoxia, then you might raise pulmonary artery pressure. But if you have small regions, small areas of low VQ, then it's probably not going to affect pulmonary artery pressure. Think back to our pulmonary circulation. Veins, right? They can distend, and as a result, it can accommodate that volume without the pressure going up much. It behaves like veins. But this is the big utility of hypoxic vasoconstriction. It is trying to match ventilation and perfusion. If I have an area of low VQ, creates alveolar hypoxia, I want to divert that blood flow away from the hypoxic area. Makes good sense. Okay, here's the last one, working with the extremes of VQ mismatch or VQ problems. Let's say that we have a small thrombus lodged in a pulmonary artery. All right, if I have a thrombus lodging in a pulmonary artery, that's going to stop blood flow, but I'll still have ventilation, so that's going to create, hopefully you said, alveolar dead space. Exactly. This is going to create alveolar dead space, and because I have alveolar dead space, that means ventilation, no perfusion. I know CO2 is going to go down. CO2 is going to go down. Oxygen is going to go up. And if CO2 is going down, that's an acid, then pH will go up. pH will go up. All right, all of these, okay, are based on the idea that the thrombus increases the VQ ratio. Okay, this produces areas that act as dead space, as we have indicated. All right, that is the idea of VQ. Now let's move on, and we're going to discuss the hypoxemias and how to diagnose them. Before we discuss the hypoxemias, let's do a very quick, and this will be a very quick review of the normal lung. Normal alveolar PO2 is about 100. Blood coming out is 100. We know this is the case because we know oxygen is perfusion limited. Again, perfusion limited means the gas equilibrates. By the time we do an arterial blood stick, though, the PO2 has dropped to 95. This is my AA, capital A, small a, alveolar arterial oxygen gradient. And this is about 5 to 10 torr in the normal individual, and this comes from blood flow associated with anatomic shunts. While we're here, let's put in the CO2. Quick reminder. Normal alveolar CO2 is 40. The blood coming out is going to be 40 because it is perfusion limited. Both gases, under normal circumstances, are perfusion limited. An arterial blood stick will give us the same PCO2. So again, end tidal is a measure of alveolar, which is arterial. End tidal is alveolar, is arterial. So that's just a quick reminder of the normal lung. All right, one cause of hypoxemia is a low alveolar PO2. Remember, we're going to use our alveolar equation, it's given to you down the bottom left, in order to estimate alveolar PO2 on step 1. This is what you utilize also clinically. Again, if they give you end tidal PO2, then they gave you alveolar. So one cause of hypoxemia is a low alveolar PO2. A low alveolar PO2 means my warehouse is low on oxygen, which means my loading zone is going to be low on oxygen, which means I'm not going to have my truck full, right? Not going to have my truck full. So that's why PO2 is low coming out. Now, I know this is hypoventilation causing the low alveolar PO2 because CO2 is elevated. So I have a low alveolar PO2 secondary to hypoventilation. And again, I know this is hypoventilation because of the high CO2. One other possible way to bring in a low alveolar PO2 we've discussed, hopefully you remember, that would be high altitude. Exactly. That's also going to create a low alveolar PO2. Now I can easily differentiate high altitude and hypoventilation as causing the low alveolar PO2. Because hypoventilation, I'm going to have a high CO2. High altitude, a low CO2 because I'm not hypoventilating. All right, we have hypoxemia, again, because the warehouse is low. The warehouse is low, arterial PO2 is low. That's what's causing the hypoxemia. So notice that we have a normal AA gradient. Now, the big question that comes next is, will increasing FiO2 help correct the hypoxemia? We're going to ask that question for all 4 of these, so pay close attention to the question. Will it help correct the hypoxemia? If you have to stop the video to answer, please do, because I'm going to go ahead and move on. But I really encourage you to try to answer before. All right. Will increasing FiO2 help correct the hypoxemia? Yes. Because if I increase FiO2, that increases the amount I have in the warehouse. And that's my problem. That's my problem. So increasing FiO2 will in fact correct the hypoxemia. So key diagnostic signs for low alveolar PO2 causing hypoxemia. You'll have a normal AA gradient. Increasing FiO2 is helpful. Most likely on step 1, the low alveolar PO2 will be the result of hypoventilation. We can recognize that because CO2 will be elevated. The patient will have a respiratory acidosis. All right, a quick little pop quiz for you. What's going to happen to pulmonary artery pressure in this condition? If you said go up, excellent, very well done. Yeah, hypoxic vasoconstriction is going to occur. We have global alveolar hypoxia. We're going to get global vasoconstriction to increase pulmonary artery pressure. All right, the bridge to pathology here. What could cause hypoventilation? Well, narcotics, general anesthetics, both of those suppress the CO2 drive to breathe. Some chronic conditions would be COPD, kyphoscoliosis, neuromuscular disorders like Guillain-Barré, Lambert-Eaton, myasthenia gravis. Anything that reduces muscular strength could result in hypoventilation. Kyphoscoliosis, remember, would be like a chest restriction. difficult to expand the chest, so that would be a restrictive type disease. And COPD, they are well known to be chronic CO2 retainers. They have a reduced CO2 drive to breathe, so they hypoventilate. So one cause of hypoxemia, low alveolar PO2, can be caused by hypoventilation. Second cause of hypoxemia is a diffusion impairment. All right, if I have a diffusion impairment, then that means I have problems getting oxygen from the alveolus into the plasma. So in other words, I'm having problems getting it from the warehouse to the loading zone. As a result, the blood leaving will not equilibrate with oxygen. So in other words, I've gone to a diffusion limited state. I'm no longer perfusion limited. Gases aren't equilibrating. Now oxygen is not equilibrating with the alveolus. So I have a diffusion limited state. Diffusion impairment means a diffusion could mean a diffusion limited state. So the oxygen in the blood coming out is low. My warehouse is fine, but what's on the loading zone is low. And that's what's causing the hypoxemia. So notice I have an elevated AA gradient. What increases the AA gradient? Well, one of the things is a diffusion problem. Now for the big question, if I increase FiO2, will it help correct the hypoxemia? Correct answer is yes, it will. By increasing FiO2, I'm going to increase alveolar PO2. This gives me a bigger pressure gradient, greater rate of diffusion, and I can correct the hypoxemia. Now, a lot of students have trouble with this at first, but remember what the question asked. The question asked, will increasing FiO2 correct the hypoxemia? The question is not asking, will increasing FiO2 correct the diffusion impairment? That is not what the question asks. You still have a diffusion impairment. The question only wants to know, if I increase FiO2, do I alleviate the low arterial PO2? Do I correct the hypoxemia? I may have to get alveolar PO2 to 300 to get arterial to 100, but I corrected the hypoxemia. Still have a huge AA gradient. I still have a diffusion problem, but I corrected the hypoxemia. Okay, that is the key point. All right, so the diagnostic signs here are an elevated AA gradient. Increasing FiO2 is helpful. All right, what are some things that could cause diffusion impairment? Well, diffusion problems occur in restrictive diseases, increased thickness of the barrier, and pulmonary edema. Again, some of those restrictive diseases are interstitial pulmonary fibrosis, asbestosis, sarcoidosis. All of these are increasing the thickness of the barrier. Pulmonary edema increases the thickness of the barrier. So here's the things to look for on step 1 that can cause a diffusion impairment, cause hypoxemia as a result of a diffusion impairment. Third thing that can cause hypoxemia is VQ mismatch from low VQ units. So we could have a region of the lung, a portion of the lung in which ventilation is compromised. There's still some ventilation there, but VQ is very, very low. So it's not a true shunt, it's not an actual shunt, but it's going to kind of act like a shunt. Because remember, as VQ goes down, oxygen falls, CO2 rises. It's underventilated. This blood flow from low VQ units mixes in with the draining of blood flow in the other areas, and that's what generates hypoxemia. Alveolar PO2, if you calculate it utilizing the alveolar equation, is going to be normal because we're going to have lots of areas of the lung that have normal VQ. So alveolar PO2 will be normal, but I have hypoxemia. So as a result, the AA gradient is elevated. All right. If I increase FiO2, does it correct the hypoxemia? Correct answer, Yes, supplemental oxygen corrects the hypoxemia. Because I have an elevated AA gradient, end-tidal PO2 is no longer reflective of arterial PO2. I have a normal looking end-tidal PO2, but arterial PO2 is low. I have hypoxemia. I have an elevated AA gradient. This is true for all of them in which we have an elevated AA gradient. So what increases the AA gradient? Diffusion problems and VQ mismatch, low VQ units. All right, some things that can cause, that we're looking for pathologically, that can cause low VQ units. Well, anything that causes severe obstruction like status asthmaticus, cystic fibrosis, anaphylaxis. Severe obstruction, I can't ventilate those areas. Or if I get some type of partial occlusion of an airway, like a mucus plug on somebody with mechanical ventilation. All right, the fourth cause of hypoxemia is an actual shunt, a right to left shunt. And again, this is only going to occur in regions. The low PO2 from the shunt, remember this is venous blood mixing in with arterial blood. And we can only have regions of a shunt. We can't have both lungs be a shunt and be alive. Right? That means there's no gas exchange in anywhere in the lungs. So the normal lung regions will have a normal alveolar PO2, but this venous blood mixing in with my arterial blood is going to cause hypoxemia. So notice I have an elevated AA gradient. What increases the AA gradient? Diffusion problems, VQ mismatch, shunts. Diffusion problems, VQ mismatch, shunts. Those are the things that cause an elevated AA gradient. All right, back to our question, the big question here. If I increase FiO2, will it help correct the hypoxemia of a shunt? The hint is it's a shunt, so there's zero ventilation. Correct answer is no, because shunt blood flow is not going to the alveolus. We're not exchanging gases, so increasing FiO2, I can't get it to where the problem is. So it's not going to do me any good. That's the theory, at least. So, key diagnostic signs: elevated AA gradient, increasing FiO2 is not helpful. Things to look for on step 1 that can cause a shunt: well, anything that causes lung areas to collapse. So atelectic lung regions, like in a pneumothorax, adult respiratory distress syndrome. If I get a complete occlusion of an airway by a mucus plug, again, mechanical ventilation, or some type of foreign body, like the peanut we talked about. That just sounds painful. We also have right to left shunts in the heart defect tetralogy of Fallot. So that's a shunt and can cause hypoxemia. Increasing FiO2 does not correct. Now, it's not 100%. As this graph shows, giving supplemental oxygen can correct the hypoxemia of a shunt if there's not a massive amount of shunt, so 10% or 20%. But what's more common in severe aspects in ARDS, adult respiratory distress syndrome, is that it won't correct because too much shunt blood flow, I can't get the oxygen to the appropriate place. So it's not 100%, but regardless, if increasing FiO2 doesn't help correct the hypoxemia, you think shunt. You treat it as a shunt clinically, and you pick it as an answer on step 1. And here's a little extra slide I've kind of given to you that's not specifically in the book as a way to diagnose hypoxemia. Again, hypoxemia is low arterial PO2. All right, what's the first step? Calculate the AA gradient. Alveolar PO2, you calculate using the alveolar area equation, or they may give it to you if they give you end-tidal PO2. If the AA gradient is normal, you have your cause. Cause is low alveolar PO2. Increasing FiO2 will correct, and for step 1, PCO2 will likely be elevated because the low alveolar PO2 will be the result will be the result of hypoventilation. If they give you a scenario where it's clear the hypoxemia is because of low alveolar PO2, but that CO2 is real low, then you know it's high altitude. They didn't let you know that you were in the Andes Mountains of Bolivia, but you're prepared for that if it were to show up. If the A gradient is elevated, next step, increase FiO2. If this doesn't correct the hypoxemia, you think shunts. You treat as a shunt clinically, you picket shunt on the exam. If increasing FiO2 corrects, then you know you either have a diffusion problem, a diffusion impairment, or VQ mismatch. Now, to separate out diffusion impairment and VQ mismatch will be the clinical information they give you in the clinical vignette. If it's somebody in status asthmaticus, then go with VQ mismatch. Someone with a pneumonia, go with VQ mismatch. If it's a patient with sarcoidosis or interstitial pulmonary fibrosis, go with a diffusion impairment. Okay? So you have to have a little bit more information on what does it look like clinically, what's the condition, and that's how you differentiate diffusion impairment and VQ mismatch. Okay, to finish off respiration, let's talk about other kinds of shunts. Let's talk about left to right instead of right to left. Left to right shunts. Now, one of the things to remember is the oxygenation status. Pulmonary venous, left ventricle, left atrium, left side of the heart has arterial blood, right side has venous blood. But the pressure gradients are to drive blood flow left atrium to right atrium, left ventricle to right ventricle. Because left atrial pressure is greater than right atrial, and left ventricular is most assuredly way greater than right ventricular. So that's the direction the blood wants to go. Well, it has to have some kind of opening to do that. And we can have openings. These are our congenital heart defects. We can have an atrial septal defect, a ventricular septal defect, and then a patent ductus arteriosus. And what we could do as a differential for these is look at the oxygenation status of the blood in the two chambers of the heart, specifically the two chambers being right atrium and right ventricle. We'll go through that on the next slide. All right, for left to right shunts, systemic arterial PO2 will be okay in all of them, but here's going to be the big differential right here. Here's the differential. Right atrial PO2 and right ventricular PO2. If I have an atrial septal defect, then I know that both right atrial and right ventricular PO2 is going to go up. So if they're giving you a clinical scenario, you're sitting there going, well, that's kind of looking like a congenital heart defect. That's maybe I wonder if that's an ASD or a VS. And then they give you right atrial PO2 is, much higher than 40. Normal is 40. And right ventricular is the same as right atrial. Then you know it's an atrial septal defect. If right atrial is still 40, no change, but right ventricular is elevated, then you know it's a ventricular septal defect. And if both are venous blood, then you know you have a patent ductus arteriosus. Now, what are going to be some of the indicators that I have these left to right shunts? Well, look at the last three. Pulmonary arterial PO2 is elevated, pulmonary blood flow is elevated, pulmonary artery pressure is elevated. In all of these left to right shunts, that is going to occur. That's going to be the impact on the pulmonary circulation. Pulmonary artery, which is normally venous blood, that PO2 is going to be elevated in all three. So that is kind of the information they may be giving you. And you're starting to question, well, is this a congenital heart problem? So in other words, they give you a patient in which pulmonary arterial PO2 is elevated, pulmonary blood flow is elevated, pulmonary arterial pressure is elevated. Well, then you know you have a left to right shunt. Now what you're looking for is what's right atrial PO2, what's right ventricular PO2. That will be the deciding differential. All right, that's respiratory physiology.